Hello everybody, and welcome to the latest in a series of webinars provided to you by UCLA Health. My name is Dr. David Merrill. I am actually a geriatric psychiatrist within the Department of Psychiatry at UCLA. I also have studied neuroscience in the past. I particularly studied learning and memory during my graduate school work, and then I came up to Los Angeles to learn psychiatry. And now I spend quite a bit of my time taking care of patients and their families for people who have dementia. So today's lecture or webinar is the latest in a series of webinars called UCLAMDChat. And as I go through the lecture, feel free to tweet in your questions to hashtag UCLAMDChat. And at the end of the talk, I'm told I'll receive an iPad, in which case I will read your questions and we'll do our best to answer them. So thanks again for tuning in, and let's get into it. So, Alzheimer's disease and dementia, facts and figures. Every year we have the good fortune that the Alzheimer's Association puts together information about the latest on what's going on with Alzheimer's disease. Currently, as of 2013, there are about 5 million people within the United States who are suffering from Alzheimer's disease. Only about half of those people are actually diagnosed. So it's actually considered an epidemic at this point. And it's not only happening in our country, it's also going on worldwide. Globally, at any one time, about 0.5% of the world's population suffers from dementia. And these numbers are only expected to increase as the years go on. We're living in an increasingly older world because we have the good fortune of living longer. But at the same time, we're facing the perils of age-related diseases such as Alzheimer's. Right now, Alzheimer's is actually the 6th leading cause of death. And so I think it's important that we educate ourselves about this condition, what we can do about it once it happens, and ultimately, hopefully, how to treat it and or prevent it. So a first question you might have, well, what is Alzheimer's? What is dementia? What's the difference? You're in luck. There's actually another webinar by Dr. David Merrill, who's the Director of Geriatric Medicine. He goes into the basics of it. The point of today's lecture is to kind of go to the next level in terms of management of the disorder. But before I get to the management, I do want to answer some basic questions just so we're all on the same page. For example, what is memory and what is cognition? So memory is actually a smaller part of cognition. Memory is not only a mental, but also a physical brain process. Our brain is made up of billions of cells or neurons which communicate with each other. Like the heart, the brain cells are actually electric cells. So they transmit signals from the cell body up the axon using electric signals. Once the electricity happens, then there's actually a chemical communication using small proteins called neurotransmitters. Neurotransmitters are released from one cell and communicate with the other cell. And the reason I'm going into this is to help explain to you later how the available treatment options work, or how some of them are thought to work. Also, another point about memory is that it actually occurs in stages. So it's not just one thing. There's learning involved, storage of information, and then of course retrieval of that information, hopefully when you need it. So as I said at the beginning of this slide, cognition includes memory. So cognition is loosely defined as the mental process of knowing. It includes things like attention, language function, memory, visual spatial capabilities, and executive function or decision-making capacity. This will become clearly important once I'm talking to you about dementia. But a couple more words about normal aging. Aging is actually the primary #1 risk factor for developing a degenerative dementia like Alzheimer's disease. So we're all kind of facing this challenge of getting older and trying to live well. Well, what can you expect as you get older? We do actually all experience a slowing of processing speeds. So think of it like a high-speed internet connection versus the old dial-up that some of us older folks used to have. Of course, now we're all streaming live, so we're up to speed. Language is another aspect of cognition that changes with normal aging. the so-called tip of the tongue phenomenon. So if I can give you an example. So if I were to show you something like, for example, my house keys, you may be able to tell me what it is, what it does, even show me how to use it, but you might forget the name of it. That's kind of the borderline of normal. This is a very common object. Usually it's more rare stuff that people have trouble finding the right word, like a descriptive adjective or something having to do with a conversation. Speaking of which, something that's hard to remember in terms of memory with normal aging are names. So especially new names that you're trying to learn, or details of recent events. So spontaneous recall of recent events decline with aging. As I get older, for example, I might have trouble remembering where I parked my car before this webinar. You know, which was the exact stall, which floor of the parking lot was it on. Now, that's considered normal. If I were to completely forget that I'd driven to the webinar, then that would be considered abnormal. So that's a change that compares normal aging versus a degenerative type memory change. So the deficits in memory with normal aging are relatively small, about 10% per decade. Recognition also generally remains stable. Now, it's not all bad news with getting older. There is this concept of wisdom, which is somewhat difficult to define. As many groups as there are studying wisdom, there are as many definitions of it. But it's sort of the concept of learning to be empathic about others, learning not to be reactive, and learning to have understanding of other perspectives. That tends to be stable or can actually increase as we get older. So, what's underlying these cognitive changes with aging? Is it neuronal loss? Back in the old days, it used to be thought that as we went through life, we lost neurons day by day. But in fact, research studies have refuted that. Some of the work that I did in graduate school actually showed that there's widespread conservation of brain cells as we age. So those neurons that I was showing you on the earlier slide, they're not dying out with normal aging. They're actually having more subtle things happen to them. If anything, as we get older, there continues to be development of new cells in parts of the brain, including memory centers of the brain. And there are actually things you can do, such as enriching your environment or exercising regularly, that can actually promote or increase development of new nerve cells in old age, or new neurons in old age. But there are changes. So the way that the neurons are communicating, both electrically and chemically, can be changing. You may see a decreased number of synapses or connections between cells. You may see changes in the neurotransmitter systems, the chemicals that communicate between cells. You may also see this signaling pathway, for example, within the neuron may be changing. So pathways that used to promote neurite outgrowth and learning may be disabled, while the actual survival pathways may stay intact. So if you were to contrast this to the point of today's talk, which is Alzheimer's disease, we'd see something different. So now that we know what memory is, cognition is, what to expect with getting older, let's ask the question, what is Alzheimer's? So to get to this answer, we need to go back over 100 years. Back in 1906, there was a German neuropathologist who also happened to be a psychiatrist named Dr. Alzheimer. And he had a patient with a peculiar disease who initially presented with poor memory and some word-finding difficulties or language problems. He continued to follow her, and over the years, she became more and more confused and disoriented about things. Eventually, she even started hallucinating. She was actually institutionalized, and she ended up passing away. At the time, he called this presenile dementia, but if you can believe this, his boss actually renamed the disorder after him. Talk about a good job. In any case, what Dr. Alzheimer's did, which made the difference, was he analyzed the brain, and he found plaques and tangles. What are plaques and tangles? Well, beyond being considered the hallmark neuropathology of Alzheimer's disease, there are also accumulations of proteins. So plaques are extracellular beta amyloid accumulations of protein, and tangles are actually inside the neurons. And those are actually hyperphosphorylated filaments of tau protein. So over time, as memory changes and memory actually gets worse, over time, we start to see a buildup of plaques and tangles from less protein to more protein. So as memory score gets worse, we see that more protein tends to build up in the brain. Now, today, there are no treatments that stop this process. We try to slow progression, and hopefully one day we will find a treatment that reverses the process. So, beyond the plaques and tangles that happen in Alzheimer's disease, there's also profound neuronal death, so loss of cells. Now you can contrast that to normal aging, where we really don't have death of cells. We have synaptic changes, communication changes, but not actual death. In Alzheimer's, memory important regions like the hippocampus, the seahorse-shaped medial temporal lobe structure that's deep in the brain, and association cortices, those are degenerating. There are also brainstem nuclei that involve transmitters like acetylcholine, norepinephrine, or adrenaline, and serotonin that are also going away. This is actually borne out on standard clinical scans today. So on the top row of images here, I have MRI scans, which are magnetic resonant images. You can see the eyes at the front of the face here with the nose, and we're actually looking down from on top. In a normal, healthy, aging brain, you see nice, plump brain. It looks good. As the brain starts to change or degenerate with the disease process, you start to see shrinkage, especially in memory areas like the medial temporal lobe. This is probably a little bit hard to appreciate on the internet, but believe me when I tell you that the hippocampus and the memory centers of the brain are shrinking here in Alzheimer's disease. Along those lines, this is actually a functional brain scan of the brain, and you see that with normal healthy aging, you have good, rich metabolism of sugar and glucose in the brain. As you get into Alzheimer's disease, there's decreases in metabolism also in the temporal lobe and the parietal lobe. That's a typical pattern of what's called hypometabolism in Alzheimer's. So I'm showing you this stuff so you have an understanding of the pathophysiologic basis of the disorder, so when we talk about treatments, you'll have an idea of what we're targeting. So what is the natural course of Alzheimer's? What are the symptoms? Early on, we have forgetfulness, word-finding difficulties. That may worry you a little bit because that actually is the same as normal aging. So I have a lot of individuals who come to me as a clinician and they're worried about, do I have Alzheimer's? I'm forgetting names. I'm having trouble remembering recent events. I'm having the tip of the tongue phenomenon. There's a lot of overlap with normal aging. Along with the early cognitive changes, there can be prevalent symptoms or psychological symptoms that didn't used to exist. So somebody who's always been very energetic, outgoing, may suddenly be apathetic or depressed. They're just sitting there like a bump on a log. They're not doing all the activities they used to do. They've dropped their interest in activities. Now the problem here, which we'll talk about in a minute, is what going on? Is that depression or is it Alzheimer's? These early features become so pronounced that they end up interfering with difficult or complex tasks. Things like keeping your finances straight, running a business, even driving a car. Later on in the development or the natural history of Alzheimer's disease, people start to develop frank amnesia, so complete forgetting of a conversation. Someone with later stage Alzheimer's might go out to a movie, and the next day they can't remember that they went to a movie, or if they did, they can't tell you what was the name of the movie or what was the plot. They'll have further problems with language all the way to the point where they're having trouble holding a conversation. Psychological or behavioral symptoms start to be more pronounced or more evolve into a more difficult state of agitation or wandering or even having trouble with incontinence. At this point in the game, when you're into moderate to severe Alzheimer's, even simple tasks become difficult. So it's important to point out here that Alzheimer's disease and dementias are not normal aging. For Alzheimer's disease and or dementia, you need to have memory loss plus deficits in other areas of cognition. That's why we went through defining what is memory, what is cognition. So these are clinical syndromes that develop, things like aphasia or difficulties with language, things like agnosia or trouble with recognizing objects, apraxias. So remember the thing I was telling you about using a key. So having difficulty carrying out visual spatial movements. So how to use a key in a door. That's a later development. Earlier would be trouble with something like driving. Or you may see executive dysfunction problems, which include problems with things like abstraction. So this level of deficit is not normal healthy aging. This is a disorder, a disease. the most common cause of which is Alzheimer's. Now, these declines, in order to meet the criteria for actually having the diagnosis, must interfere with daily living. As I've talked about, in the mild to moderate stages, it interferes with the most difficult things we do: work, keep track of money, shop, cook, drive. Later on, the more basic tasks get impacted, things like bathing, dressing, using the restroom, or even eating. So, to review, and then we're going to jump into how to manage these things, there are several categories or stages of memory loss. Now, these have had recent revisions by Alzheimer's associations and expert panels, but I think clinically, this is the way I've presented it is still a pretty clear way to think about it. So there's normal aging, in which you have changes in memory and cognition which do occur, but they're relatively mild and they don't impact your function. With getting older, there's about a 1% risk per year of developing Alzheimer's disease. Now, if changes get a little bit worse, it's called mild cognitive impairment. So you'll have deficits that you've noticed in memory and cognition, and also if you go to a neuropsychologist, they'll actually agree with you. You'll do testing and they'll say, hey, you know what? You didn't do as well as we expected based on how well educated you are, how old you are, and whatnot. The cultural context of your testing results will determine whether or not you actually have statistically significant deficits. If you've noticed memory cognition changes, you have testing deficits, you meet the category or criteria of a diagnosis for mild cognitive impairment. Here, your risk for Alzheimer's disease jumps up from 1% for normal aging to 10 to 15% per year for MCI. Now, this risk does not mean a definite progression to Alzheimer's. After about 5 years, only roughly half of people with mild cognitive impairment go on to develop Alzheimer's disease. The other half don't. This is part of what our group at UCLA is researching, and others across the country and the world are researching. What's the difference? What predicts decline into dementia versus stability or sustaining the level of function and basically how people are doing? What determines that differentiation, and how can you get yourself into the stable group? That's the group that I'd like to be in some years from now. Now, dementia has all three: changes in memory and cognition, neuropsych testing deficits, and then also deficits that interfere with daily living. Now, who determines what's interfering with daily living? You might have a loved one who's having memory problems who says, guess what, honey, I'm fine, there's no problem. And you may have a spouse who's saying, doc, let me tell you, there's some problems. So that's where we're getting into evaluation and management of memory loss. So management of memory loss begins with a good, thorough evaluation. You might be sitting there wondering, I have a loved one I'm worried about, what should I do? Well, you can start with a primary care visit. If that's not sufficient, you may go to a geriatrician, someone like Dr. Rubin. You may go to a neuropsychologist like Dr. Erkele, who's part of our lecture series as well, or you may come to me, a geriatric psychiatrist. All of us are basically going to be performing a similar type of evaluation that still, to this day, begins with a clinical interview, the history and evaluation. We'll do a mental status exam, do some screening, mental tests to see how you're doing. The most common example would be trying to remember 3 words, draw a clock. I'm not trying to give you a cheat sheet to do better, but that's the kind of test we'll do. We have some other tests in case you practice those beforehand, just to find out how you're actually performing. We'll do physical examination, get collateral from your loved ones, and then also do a thorough psychosocial assessment of your situation, how things are going at work, how's it going at home, how's it going with your relationships. Once that initial appointment is done, we'll send you for lab studies, brain imaging, and if needed, we'll actually send you for neuropsychological testing. The next step, once the evaluation is done, is to treat any reversible causes of memory loss that the evaluation has found. So, for example, depression. Depression can cause slowing of processing speeds, some problems or perceived problems with memory. So you treat depression, the memory loss lessens, and you're doing better. There are other lab-based tests that can determine problems with thyroid or vitamin levels. Structural lesions can be found by imaging. There may be infectious process or toxic processes going on that can hopefully, at the very least, be treated, if not fully corrected, that can lessen your memory loss or memory problems. Another step that can go on simultaneously with evaluation is looking at your medications. It's very important to be stopping memory toxic medications. Now, younger adult psychiatrists and adult psychiatrists kind of get to be doctors who prescribe lots of very well-used and effective medications like anti-anxiety medications, sleeping pills, pain pills. Myself, as a geriatric psychiatrist, I get to do the reverse. I get to take away the sleeping pills, the anxiety pills, the pain pills, if and when memory loss becomes so profound that it's actually interfering with function. So a very key step before jumping to a diagnosis of dementia is to discontinue memory toxic medications. You can see awakenings or astounding improvements from getting off medications that are causing problems with memory. Once the workup is done, hopefully things are better, but if not, you've kind of reached a point at where you're probably looking at a dementing syndrome or a dementia. Now, we've talked about dementia is a syndrome of memory and cognitive loss that impairs function. The most common cause of dementia is Alzheimer's disease. I've got a pie chart here that's showing roughly 70% of cases of dementia, the syndrome, are thought to be caused by Alzheimer's disease, the process. Plaques and tangles, cell loss in memory areas in the brainstem. There are other causes of dementia: vascular disease, dementia with Lewy bodies, Parkinson's disease, FTD. The list actually goes on, but we've only got a 1-hour webinar plus or minus. So I'm going to talk about these more common forms, and there are other forms that perhaps will be later webinars or other information on the web. Managing dementia. We've gotten the evaluation, we've corrected reversible causes, we've cleaned up the medications. So now that I've taken away some medications, guess what? We're potentially suggesting some new medications. Don't take those, take these. If you indeed are suffering from Alzheimer's dementia in particular, you should be considering going on what's called a cholinesterase inhibitor. Now remember, a few slides ago I talked about acetylcholine. It's one of the neurotransmitters that communicates between cells. Cholinesterase inhibitors actually work by preserving the intactness of acetylcholine, which is one of the neurotransmitters that allows cells to talk, nerve cells to talk in between each other, or neurons. So cholinesterase inhibitors are medications that support the function of cholinergic neurons. They may help with attention and memory, and they may actually delay placement into nursing homes in cases of severe Alzheimer's. Now, these drugs, there are several available on the market. The generic names are things like donepezil, galantamine, and rivastigmine. You might talk to your doctors about these if you're facing Alzheimer's disease. And I'll show you some data in a minute to what size effect you can expect from these medications. Now, another class of medications just has one member. That's called memantine. Now, memantine works differently than acetylcholinesterase inhibitors. Memantine is preventing glutamate-induced neurotoxicity. That's a mouthful. But suffice it to say, the idea is that basically it's preventing death of cells in the brain. Now, for both these medications, the data looks somewhat similar. So here was a data result from a clinical trial that allowed approval of donepezil, or it's known by its brand name Aricept, to be approved by the FDA for prescription in Alzheimer's disease. The study was basically a number of weeks, and at the beginning, people were divided into either 2 doses of Aricept or a placebo, a look-alike pill. After the trial had concluded, or at the end of the trial, they measured cognitive function again, which had been measured at the beginning, and they found that there was less decline in the groups that had the drug, and the difference is considered the treatment effect. Now, it looks very impressive on a slide, and for some patients it is. About 25% of patients have a robust or good response to the medication. However, bear in mind, this scale is showing about 10 points on a 70-point scale. This difference is about 4 points, which is considered, so the whole scale is 70 points because it keeps going up and down, and the effect size is about 4 points. It's considered clinically significant, and as I mentioned, it may be helping attention, memory, and delaying placement. So we do recommend using these drugs in Alzheimer's disease. It's not preventing progression of the disorder, however. So it's not modifying the disease, it's just slowing the progression. And you can see what they even did was they showed that if you take everybody off the medication, that's several weeks later, everybody's performance drops. So you need to stay on these medications if they're benefiting you without side effects. And it's a similar story for memantine or Namenda. So you see there's a slope for people who are taking the active drug, and then there's a slope for people who are not on it. and at the end there's a difference that's significant. Now, Namenda is only, this is a different cognitive battery. It's indicated only for moderate to severe stages of dementia, and it may or may not be beneficial to be on both types of medication at once. It's just not fully known. If you can tolerate both, I generally am recommending that people try them both out and see how it goes. Now, I am a psychiatrist, so I end up seeing a lot of cases of Alzheimer's disease and dementias that need help, that they not only have cognitive problems, but they have behavioral symptoms. So remember, at the beginning of Alzheimer's, it's apathy and depression. And the question is it just depression, or is it depression and Alzheimer's disease? So I try to help patients and their families parse out what's going on. We try to get the depression treated, and if memory improves, great. If there's still a memory problem, we start talking about dementia. So, but before we go into prescribing medications and doing things, it's important to start determining the causes of what's going on before you're jumping into treatments. So, if we've gone through evaluation, we've treated reversible causes, and we've determined that there's a dementia, if somebody comes into my office or calls in with new symptoms, the first thing we want to do is determine the causes of what are the new, if there's new behavioral symptoms, we try to determine what are the causes of these new symptoms. Is it an acute medical condition? Did we try a new medication or change the dose? Is there something new in the environment or the psychosocial situation? Or is it really purely from the dementia disease process, the loss of cells, the atrophy in the brain? Is that what's going on? So I want to introduce a concept and then we'll move on. This concept of homeostasis. In biology, there's a concept of homeostasis, or reaching balance and equilibrium. As people get older, and also for people who develop chronic diseases like dementia, there's a narrowing or a stenosis of reserve capacity. So something that used to be a nuisance becomes a major big deal. Like, for example, acute medical conditions. You can have urinary tract infections, or broken bones, or even constipation can really tip the scales, so somebody goes from being at their normal baseline to being acutely confused and sort of out of control, presenting to the emergency room. So if you have acute causes of a behavioral symptom, the first thing to do in treating these causes is not to jump into psychotropics. We're just basically going to try to use non-psychopharmacological approaches to treat the causes. So reverse or treat any identified acute causes. Once those are all taken care of, or if there are none that identified, even still before we go to psychotropic medications, we try to modify the environment that the person is living in. So is there a way that we can either avoid or fix the stressor that's causing the behavior to make it better? You know, can we put ways that if somebody's wandering, can we change it so they no longer can wander? If something is causing a problem, if the task is too complex, can we make it simpler? So in advanced dementia, if somebody's having trouble eating, can we give them assistance eating? Are we trying to keep the activities appropriate for the level of dementia that exists? So again, later on in this disorder, you might be trying to do things for people that they can no longer pull it off, or trying to have them do things they can no longer pull off. So it is really important to keep realistic expectations both for the patient and the loved one in terms of non-medication approaches to treating behavioral symptoms. Second, or actually it's more like fifth or sixth or seventh, we do at times turn to medications for specific target symptoms. So if we have something that looks like depression and anxiety, we may try an antidepressant. If we see something that looks like hostility or suspiciousness, paranoia, things that are out of touch with reality, which basically defines psychosis, we may try antipsychotics. However, it's important to bear in mind that there are actually no medications that are approved by the FDA for behavioral disturbance in dementia. So here, you really want the help of behavioral experts combined with the help of physicians who are specialists in this area to determine whether or not it's right to use a medication. So, as I just stated, use of medications in behavioral disturbance with dementia involves discussions. It's a shared decision-making process between patients, loved ones, and their doctors or specialists. It's important to look at, what are the quality of life goals? What's the risk-benefit analysis for the drugs? I talked about possibly using very powerful antipsychotic neuroleptics to treat agitation, hostility, suspiciousness. Well, it turns out there's also black box warnings about these drugs that they're not to be used in behavioral disturbance and dementia, that they're associated with increased mortality of all causes. There may be cardiovascular and metabolic effects of these medications over time that tip the scales in one way or the other in terms of a risk-benefit analysis. So here you really want to reserve medications for severe symptoms and things that don't respond to behavioral non-pharmacological measures. If you are turning to medications, you want to try minimal effective doses to avoid side effects. And you want to continually reevaluate whether or not there's improvement. After all, I'm a big believer that there's no point in being on a medication if you can't define the benefit. And you should really expect improvement behaviorally within 2 to 4 weeks, so a relatively short time frame. Follow-up once a medication is prescribed should certainly be within a month, whether it's a face-to-face appointment, calling over the telephone, or perhaps streaming live over the internet. No, probably not that one. But in any case, you want to be reevaluated over time for improvement. And once somebody is stable, you may consider tapering the medication or stopping it. Some initial evidence showed that that was safe to do, that was okay, there was no problem with that. More recent study has come out that it may actually be problematic to stop the medication, and you may risk having the behavioral symptom reemerge. So this really goes back to the risk-benefit analysis and what was the behavior that you were treating? Was it feeling suicidal? Was it throwing items at a caregiver? In that case, you may not want to risk stopping the medication if there's no obvious downside. If it was something more benign and the patient is really resolved and it looks like some acute stressor is resolved, you may be more in a position to taper the medication. So it all depends. So that approach that I've just whirlwind discussion of the approach of evaluation, diagnosis, management of Alzheimer's disease, which again is the most common form of dementia, gives you a taste, a beginning of where to go with this, who to approach to talk to about it. Your primary care doctor, a geriatrician, a psychiatrist, a neurologist. That's just kind of the beginning for Alzheimer's, the most common cause of dementia. What I'm going to spend the rest of the time for the prepared talk is to go over some of the other common types of dementia and highlight where the management is the same versus different. So, if you remember the pie chart, the second most common cause of dementia is actually vascular dementia. Now, within vascular dementia, there's different types. So you don't just have one type of vascular dementia, you have subtypes. And depending on what type of stroke you've had, you'll end up with different deficits. So whereas in Alzheimer's, there's a pretty prototypical progression, in vascular dementia, it can be quite varied, and it can be more of a stepwise decline. If you're having multiple large strokes, you're basically getting more deficits every time there's a big stroke. If you just had a strategic set of strokes, you may not get any more strokes if you change the underlying cause. Or you may have a completely different looking picture of subcortical strokes. We'll talk a little bit about the differences. It's a little beyond the scope of today's overview webinar, but perhaps in a future episode. In general, vascular cognitive impairment or dementia presents with a slowing of thinking. So again, the connection speed being lower than you would want or lower than expected. There's also pretty prominent executive dysfunction, so the CEO of the brain, decision-making, stability of mood, motivation, these tend to be impaired with vascular cognitive impairment. There can be a relative preservation of memory function, which can be somewhat perplexing. So someone's slowed down, they're having trouble making decisions, but their memory is good. So you think, well, this may not be Alzheimer's. In fact, it may be vascular dementia or vascular disease. So how does one go about treating this condition? Well, a couple important things. Number one, similar to Alzheimer's, you want to be taking care of general health. So treat any known vascular disease, things like cardiac conditions, even more simple things like blood pressure, cholesterol, blood sugars. This is all in an effort to prevent further cerebrovascular disease. So you want to have optimal medical management. Sometimes people don't like going to the doctor. They don't like taking medications. Well, here's a case where you can really save yourself a lot of trouble and grief if you kind of change your frame of reference. if you can prevent damage and you only have vascular problems going on, you can actually stop progression cold. You cannot get any worse by controlling some very straightforward things. Now, if significant cognitive symptoms have already developed and you're wondering, well, is it helpful to take cognitive enhancers? The question is, the answer is maybe it is, maybe it's not useful. Both the cholinesterase inhibitors and memantine were developed relating to research of Alzheimer's disease and that degenerative process. They weren't developed for strokes. So in so-called pure vascular dementia, where there's no degenerative Alzheimer's process going on, the evidence is mixed. The medications may be helpful, they may be not. Well, why would this be? It turns out that it may be because somebody's experiencing the very beginnings of Alzheimer's disease. In other words, they might have two things going on at once, a so-called mixed dementia of both Alzheimer's and vascular disease. Behaviorally, what do we see? Again, when the cases are difficult, they end up in my office seeing a psychiatrist talking about, my loved one never suffered from mental health issues, never had problems, and now the most common things we see is that there's depression, agitation. Upwards of 30% of individuals with vascular dementia have one or the other or both. Then you also have that apathy, which can also be strangely mixed with an irritability or an anxiety. And in worst case scenarios, you have psychotic symptoms and frontal symptoms of disinhibition, which we'll talk a bit more about in the coming up slides. So unfortunately, similar to the case for Alzheimer's disease, there are no drugs that were developed specifically for behavioral disturbance in vascular dementia. However, when the risk-benefit is right, we will try out psychotropic or psychiatric medications to try and treat specific symptoms. If somebody has low energy and apathy, we may try an antidepressant that's energizing and uplifting. If somebody has suspiciousness or has some false beliefs about what's going on, we may try an antipsychotic if the decision process puts us in towards the direction of saying, yes, it's worth it to try out this medication. With all the same management considerations as before with Alzheimer's disease. Constant reevaluation of the usefulness of the medication, constant monitoring for safety and for side effects. Dementia with Lewy bodies. This is the discoverer of the Lewy body, Dr. Lewy, who discovered Lewy bodies long enough time ago that it was black and white photography, so it means it's a while ago. In any case, you can Google Dr. Lewy to find out the full story. For the sake of discussion here, what's important is that these are pathological or histological hallmarks of dementia with Lewy bodies. This is an intracellular inclusion body made up of a different protein. Alzheimer's has beta amyloid and phosphorylated tau. Lewy bodies have alpha-synuclein, another type of protein that researchers are trying to target to help prevent or reverse dementia with Lewy bodies. This pathology can also be found sparingly in Alzheimer's and or in Parkinson's, but tends to be in different parts of the brain. So why do we have another disorder called dementia with Lewy bodies? Well, it turns out the symptoms are different. So the core features of Lewy body disease or dementia with Lewy bodies are fluctuations in cognition, having visual hallucinations, and having Parkinsonism. So good days and bad days, or even good moments and bad moments. Trouble with gait or balance, mass facies, like slowed gait, hallucinating particularly small animals or small people. These are core features that might have you think, oh, this could be dementia with Lewy bodies. If there are psychotic symptoms, you might want to try out, you might be tempted to try an antipsychotic or neuroleptic. If somebody has a difficult problem with side effects, that's actually a feature suggested of this in true case being Lewy body dementia, because people with this disorder are exquisitely sensitive to these medications. So what is the medications that are used here? You can treat the Parkinsonism, that's the first thing, kind of the medical component of it. And for the neuropsychiatric symptoms, the cognitive and behavioral symptoms, there is actually a fair amount of evidence that particular cholinesterase inhibitors help the cognitive problems and even the behavioral problems of Lewy body dementia. And then memantine is worth a trial at some point in the disorder. The evidence base is not as strong or extensive for these other classes of psychiatric medications, But again, if it looks like depression, perhaps try an antidepressant if it's needed. Other things to normalize sleep patterns and whatnot. Now, I mentioned that Lewy bodies are at times seen in Parkinson's, but in different parts of the brain. So you may be asking, or you may be saying, like, I have a loved one, or I knew someone who had Parkinson's disease and developed dementia. Indeed, there is a condition, Parkinson's disease dementia. I'm not going to have time to go through all the particulars, but the management is similar to dementia with Lewy bodies. And here, sort of definitionally, the distinction is in that in dementia with Lewy body, you have close to simultaneous onset of the cognitive and the motor symptoms. Whereas in Parkinson's, the person will typically have had a neurologist for years who's been treating Parkinson's disease, and it's only much later in the progression of the disorder that they're having functionally disabling cognitive symptoms. It's a similar story with the cognitive enhancers and the psychotropics. They're worth a try to see if they benefit, looking for changes with memory function and or preserving function at a stable level over time. So the last specific type of dementia I'll look at today, and then we'll open it up for some questions, is one of the most common types of dementia to get referred to a psychiatrist because it's impacting the frontal part of the brain. You may have heard of somebody being frontal. Well, this is frontotemporal dementia. And here's some metabolism shots. Here the blue represents cool or low metabolism in the front of the brain. And also here structurally there's atrophy. This gray color means a loss of brain tissue in a structural MRI. FTD, the frontal parts of the brain are atrophying, and also the anterior temporal parts of the brain, those by the ears, so the front and the front by the ears, those are degenerating. Luckily, FTD is much more rare than for example, Alzheimer's disease, but when it comes on, can be very devastating. There tends to be an earlier onset in people's 50s. The decline is more rapid. Average survival is only 3 to 4 years after diagnosis. If you compare that to the natural history of Alzheimer's disease, average survival is about 8 to 10 years after diagnosis for Alzheimer's disease. Probably has to do with the underlying pathophysiology, but in any case, it is what it is. For cognitive symptoms, FTD, there's prominent executive frontal dysfunction and also language deficits. Below here, I've listed some of the neuropsychiatric symptoms, and it's a litany. They're present in over 90% of cases here. I've had cases where well-intentioned clinicians have told me, like, my patient does not have dementia, meaning like their memory is normal, but in fact you do the evaluation and they've got these more subtle cognitive problems, executive dysfunction, language deficits, along with the behavioral symptoms. I've actually included a slide here just to talk about one type of behavior that's seen or one class of behavior seen in FTD patients. That's sociopathic behaviors. So people who've been upstanding citizens all their life, they have a degenerative dementia, which is a brain disease with very significant changes in the brain structure and function, and suddenly they're doing things that just don't make any sense. You know, hit and run traffic accidents, physical assaults, shoplifting, stealing, not being able to prevent themselves from eating. There's a very classic video of a family around a holiday dinner table, and the loved one who's affected with FTD, at some point in the meal, when they're finished with their food, they actually pick up the plate and start licking the plate. So that sort of act, well, it's not really sociopathic, it's more just disinhibited, that defines FTD observationally, and it turns out it's borne out its underlying brain circuit dysfunction. And depending on which circuit in the brain is dysfunctioning, this is the frontal lobes here, this is the brainstem here, depending on which brain circuit is dysfunctioning, you'll get different symptoms. You can have disinhibition, you can have apathy, you can have decision-making problems. What do you do in these cases? How do you manage it? I've included a pharmacotherapy slide, but in fact, these FTD cases are the most important to manage behaviorally and psychosocially. Getting a safe environment set up, getting a structured environment set up. For the medications, the cognitive enhancers were not developed for the disorder. There's limited to no evidence in supporting their use. Now again, if they have two things going on at once, if they happen to have FTD and Alzheimer's or a frontal variant of Alzheimer's, you may want to try it. This is again where the evaluation is critical to determine whether or not to try these medications. There's some support for use of antidepressants, weaker evidence for antipsychotics, and it's really just not known in terms of the mood stabilizers whether or not they're helpful. But as the symptoms get more severe, families and doctors become more compelled or desperate, for lack of a better word, to try something. And it is reasonable to try these things if the risk-benefit really is in favor of preserving independence. So if somebody is having out-of-control disinhibition or aggression or anger, that may actually cause them to be displaced from the home. And this is not only the case in FTD, but can also be the case in Alzheimer's, Lewy body, really all the types of dementia we've talked about today. So in summary, I just wanted to close the structure part of the talk by reviewing that we now know that dementia is a common syndrome of aging. Alzheimer's disease is the most common cause of dementia, which accounts for about 70% of cases. There's been recent progress on what's the pathogenesis of the disorders, what are the subtypes of the disorders, how can we diagnose these problems earlier and earlier so families can know that it's time to make decisions and make plans. Treatments. There are symptomatic treatments available, but they're really not satisfactory in terms of their effects or outcomes. The disease-modifying agents, the holy grail of Alzheimer's dementia research, really don't exist yet. There have been a lot of high-profile failed clinical trials, and there are several more large clinical trials planned and ongoing to try and find that disease-modifying therapy. As of yet, does not exist. As such, the psychosocial assessment and support are essential for managing the disorder, which is ironic because I'm a physician and I'm telling you that basically at the current state of affairs, it's most important to have a support system that involves a lot of non-physicians as well. So here at UCLA, we now have this dementia care program, which is based on case management by a nurse practitioner in conjunction with the primary caregiver. We have the Longevity Center at UCLA, which is both an educational center and a support center for families and their loved ones struggling with Alzheimer's disease and related dementias. On the national level, there's the Alzheimer's Association, which is a strong advocate for patients and their families, and Caregiver Resources Center, which can help you with all types of not only dementias, but other chronic medical conditions. So, that's the scoop for the structure part of the talk. This is who I am. Again, I'm a geriatric psychiatrist at UCLA. UCLAhealth.org has a web page for me. You can look me up, take a look. I'm both an adult and geriatric psychiatrist. I'm researching memory disorders, what to do about them, how to treat them. And now I would like to open it up for questions coming in through emails and Twitter from hashtag UCLAMDChat. And so we'll spend a few minutes answering some questions, and then we'll wrap it up. Thank you. Wow, okay, so first question, which I think is a great question. Is there anything I can do now to prevent Alzheimer's or dementia? It's interesting. I just recently wrote a review article with one of my supervisors, Dr. Gary Small, who's written an Alzheimer's prevention program manuscript about what to do to try and help prevent Alzheimer's. There is no one strategy that can fully guarantee preventing Alzheimer's. However, the idea is that healthy lifestyle behaviors may confer a slowing of a progression of a memory loss, which if you push it out far enough may actually prevent you from developing full-blown symptoms or symptoms that are very severe. So far, the national and worldwide evidence base implicate two healthy lifestyle factors most for preventing progression to dementia. Those factors are exercise and adherence to Mediterranean-style diet. So with exercise, you want to try to adhere to American Heart Association guidelines, things like 20 to 30 minutes, 5 days a week or more, 150 minutes a week of moderate intensity activity, aerobic activity. Get your heart pumping, get your blood circulating, in any case, things like that. So there's a number of questions here. I've got about 10 questions piled up, so 10 minutes. Let's see how much we can get through. Okay. The next question talks about what are the naturopathic remedies beyond, wow, it only says what are the naturopathic remedies for moderate Alzheimer's, but then they list like 3 of the answers I was going to give, like turmeric, which is also known as curcumin, or fish oils, or things like perhaps ginkgo, or they talk about Chinese moss. What are the other naturopathic remedies that I can talk to you about in this setting really rapidly? Well, the truth is that the complementary and alternative medicine approaches, as they're collectively known, that is outside of Western medicine, the complementary and alternative medicine approaches are still in development. Things are not in prime time. There's not something that the doctor currently today is recommending to everyone who comes through with Alzheimer's disease. For a time, we thought that vitamin E was one of those compounds, but then later it turned out that in fact, no, there was not significant benefit and there was in fact some risk to it. So it's no longer in favor. Similar cycles have gone through for other compounds, and really that's the stage we're at. Really, I would more talk about in terms of CAM therapies. I'm really a big proponent of physical activity and basically a healthy, non-processed food, whole foods diet, a plant-based diet. So there's a question about chelation, hydrogen peroxide, chelation therapy, hydrogen peroxide. Isn't it hydrogen peroxide toxic, even if it's food grade? Well, here it's a similar answer to the other question about this CAM therapy. This would fall into the alternative mode of therapy. It's just not something that's in prime time. It's not something I can definitively recommend. I like that the question is saying like, well, what are the risks of this treatment? And if you're going to try and use any alternate therapy, you want to know what's the information about the risks compared to benefits. I would also caution you to think about the costs involved. Something relatively low cost may not be a problem if it's generally considered safe. Anything high cost that has risks, you might want to stay on the sidelines for that one until it's more mainstream. Okay, is there a special type of doctor I have to see to distinguish between Alzheimer's disease and dementia? So, not necessarily. So Alzheimer's disease, again, is one type of the syndrome of dementia. Happens to be the most common type, has a very prototypical presentation and development. So if Alzheimer's disease is what's going on, many generalists, primary care physicians, family physicians, are actually the best diagnosticians for common disorders. So a common disorder presenting commonly, that can be diagnosed and treated by a primary care doctor. It's when you start getting into the complications. Does somebody have Lewy body or Lewy body variant of Alzheimer's? Do they have behavioral disturbance that the primary care doctor or neurologist can't handle? That might be when you go see somebody like me, who's a specialist in geriatric psychiatry. Are there any new medications that will help with memory loss or dementia? That's a great question, and one of the upcoming webinars for UCLAMDChat is actually going to be by Dr. Josh Grill. He's going to talk about emerging therapies and approaches that are being tested both here at UCLA and nationwide, and in fact worldwide. There are multinational studies going on for new medications, but I'm going to leave that to Dr. Grill, so hopefully that will encourage you to come back. I've presented today kind of what's standard of care, what's available, and will be future sessions about what's up and coming. Why do we face memory loss in Alzheimer's disease? So, towards the beginning of the talk today, which you can view these webinars on demand. So if you go back towards the beginning of the talk, there are actually some slides about the brain changes that happen with Alzheimer's disease. Now, the parts of the brain that control motor function and sensory function, those are spared. So the motor strip in the brain, the sensory strip in the brain, those are spared. And so people maintain their physical function well into the development of Alzheimer's. It's only very, very late in the disorder that they start having not being able to walk and that sort of thing. So in contrast, the memory areas of the brain, remember memory is a brain process. The memory areas of the brain are degenerating very early in this disease process, and they're exquisitely sensitive to changes. So by the time that Alzheimer's disease is diagnosed, even in early Alzheimer's, you may have 50 to 90% cell loss within certain layers of the hippocampal cortex, which has different layers of cells. So the reason we face memory loss of Alzheimer's, it's attacking the parts of the brain that form new memories. Next question. I heard that coconut oils can help with Alzheimer's disease. This kind of lumps back into the CAM therapy questions, the complementary and alternative medicines. Some people have demonstrated that shows initial promise, hasn't been definitively evaluated. Let's all hope that it is the case. We'll have to wait and see. Does aluminum play a role in the development of Alzheimer's? Aluminum was one of the earlier or longer ago theories about the causes of Alzheimer's, caused a big worry at the time about using aluminum cookware or having aluminum. That was essentially no longer thought to be the case. I guess you would say it was a theory that was debunked. But then again, we haven't figured out what is causing it. So, but in generally, aluminum is considered not to be the thing. It's not in favor as the explanation. Just recently, there have been a couple other metal stories. So there was just a mouse model story about copper possibly being the causative agent for Alzheimer's. And here at UCLA, there was just another study about iron being possibly responsible, iron accumulating in the memory centers of the brain being the cause. Again, probably a little beyond the scope of today's discussion about management of the disorder, but important questions because we're all thinking the same thing. It's like, how do I avoid developing Alzheimer's? Are the drugs, this is the last question I have at the moment. It says, are the drugs for Alzheimer's disease effective? Now, again, on-demand webinar, kind of the middle of the talk. There's a couple slides about the effect size of the medications and what they're doing. So, for example, the cholinesterase inhibitors, medications like donepezil, for example, the generic, that is slowing the progression. Instead of the slope, the disorder going really fast, the progression is slower. It's still progressing, so it's not stopping the death of cells in the brain, but it's augmenting the function of these cells. So we're still holding out hope that we can find a treatment that stops disease progression. So the answer to the question is no, we don't have anything that stops disease progression at this point, but yes, in fact, they can be effective for some patients and help slowing the progression. So those were the questions I had. Potentially there may be another question or two. I want to take this opportunity to thank you all for participating, and let me answer this one more question. Okay. Are there any links between community management of Alzheimer's disease on family-based maternal and child health care in Africa? Does that mean, do I know links to do that? Not sure. So, question. Feel free to follow up with me to hopefully get a clarification of this question. You can send another tweet or you can send a shout out about this, UCLAMDChat. We can try to get to the source of this question. For the sake of time right now, I'm going to bring the webinar session to a close. And I want to remind you that you can see this session and the other sessions of UCLAMDChat on demand on the internet. And again, I enjoyed the discussion with you, and I look forward to the next time that we have a chance to talk. Thank you again.